Okay, so last class we started with surveillance, and this is a common term that we hear in public health or epidemiology. Epidemiological surveillance, public health surveillance. That's a very common term that we hear. And I told you what is the difference between surveillance and monitoring. Monitoring will be like every 3 months we do monitor, and in between they are not monitoring. Just every 3 months they suddenly remember about this. But in surveillance, because it is about the health diseases and it can happen on any day, we can't just wait like monitoring every 3 months or 6 months we will do. So in case because it is health, we have to continuously monitor, and continuous monitor we can say that it as a surveillance. So it is always ongoing. We collect the data, we analyze the data, interpret what is the meaning of that data, and why we do all these things to make a planning. If there is a new disease coming up or something that is increasing, then to make a planning to implement it. And if we are already doing some preventive program for that disease, if it is increasing, then to escalate the activity, or if it is decreasing, then reducing it accordingly. So to evaluate and closely integrate with the timely dissemination. Whatever we do, we have to finally disseminate our ideas or whatever our findings is. Otherwise, there is no meaning in collecting the data. So when we do the surveillance, it is actually giving us the descriptive epidemiology. Means when we are doing the surveillance, we consider which population is affected, what are the symptoms they are having, which age is more affected, which gender is affected, if there is any time variation, seasonal variation, etc. So when a disease is described on the basis of person, time, and place, then that means the descriptive epidemiology. We are giving the descriptive, and only when it goes towards the statistical analysis, it becomes the analytical epidemiology. So while we do surveillance, we are just collecting the data based on these three subheadings: person, place, and time. So what we are ultimately having is a descriptive epidemiology. And who performs? Epidemiologists, the people who do MSc epidemiology or MPH, Masters in Public Health, they can become epidemiologists. So those people may be doing the medical professionals, some doctors, nurses, clinics, in the sense that some diseases comes to us, we need to report it to the government. Pharmacies can do because they need to give a report on what all medicines they have sold. So from that, we can get an idea. Health insurance providers, emergency responders, public health department, be that local, state, or the central. So these people, in a way or another, they are doing the surveillance. And why do we use? Simple enough to know what is the magnitude of a disease in a population, and if there is any epidemic that is coming up, which population is more affected, where we need to give more care to get the natural history of a disease, etc. And if there is any change in infectious agents. And how do we get this public health data? We already told that who are reporting it, and what are the sources, like what are the documents we get the surveillance data. For example, if you want to do some research project and you want the data of a particular thing, like how is tuberculosis now in Malaysia. So you want that data, from where you will get it. You can go for the vital records like hospital records, death certificate, birth records, not for tuberculosis, but for any other thing. Then you can conduct a survey in the school if it is seen in younger people, or if it is adult, you have to go according to that, do the survey in colleges or higher educational institutions. Doctors, insurance companies, from environmental monitoring systems, especially if you are going to do some water related diseases. So water pollution, you need to know about the level of pollution in that area. So then you have to go to the concerned department, which monitor the pollution of water bodies or even the air around. Then animal health data, if it is a zoonotic disease you are going to study, then go to the veterinarians, the farms, food manufacturing units, etc. Then how we collect? There are like we can do the voluntary reporting, individual persons reporting, a person, doctor, or hospital. It can be a media report or some unusual health occurrences, excessive school absence, or higher purchase of specific pharmaceutical. Like voluntary reporting is a type of passive surveillance. We'll see later passive surveillance. Uh, the people who are doing the surveillance, like what we told the epidemiologist in public health department of the government, the people who do surveillance, they're usually called as the epidemiologist. So they actually sit in their office. They are not doing anything. That is a passive surveillance, and the people will be reporting to them. So it is a kind of voluntary reporting. Like one of the clinic, they are having a case of mumps, and then mumps has to be reported. So they are reporting to the public health department or the concerned official. See, I have got such a patient report. So that is a voluntary reporting, or it can be even a media report. A person or the media, they see that a particular disease is seen in a particular area, some common symptoms. So they just give it as a report. Such a condition was seen. So from that, it is a voluntary reporting. For some people saying about any unusual health occurrence, well, it is done voluntarily. Whomever people giving the data, they do it voluntarily. Then it can be public health initiated service, that is a part of active surveillance. The epidemiologist or the people who are collecting data, they are involved actively in it. So they call into the hospitals, the clinics, some areas, healthcare facilities, and then they take survey, complete their forms, giving some questionnaires, and then they are collecting the survey. So that is a kind of active surveillance. And then the most important one is mandatory reporting. Mandatory reporting, there are some diseases which are called as notifiable diseases set by WHO, and that is some international diseases which are seen internationally. And every country will be having their own set of certain diseases. So we are supposed to inform the government. We should be having a knowledge about what are the notifiable diseases of this country. Like if you're practicing here, you need to know what are the notifiable diseases. And if a patient is coming to you with that particular disease, you need to report it to the concerned public health department. So it is mandatory, and if it is not happening, then they can take any action upon you. So that are called as the reportable or notifiable disease, where we have to, where the medical professionals are bound to report such and such case had come to us and what we have done. So, highly communicable diseases like chickenpox, high morbidity or mortality rate diseases like Ebola virus disease. Now, this is general examples, but it will vary. It will vary according to the country also, and there are certain diseases set by WHO. Yellow fever is one among them. So, some diseases are the where we have to mandatorily report. So the public health surveillance based on how we collect, as I already told, there are three types: passive, active, and syndromic. And now this is important to understand the difference between what are the three types. So passive, as I already told you, you are just collecting the data. I mean, the epidemiologists, they are not even collecting the data. They are sitting in the office and people are voluntarily reporting to them. So these people who are collecting the data, they are not doing any active intervention or prompting. They're just sitting in their office and the data is reaching to them. So they wait to the healthcare providers, hospitals, lab, other reporting entities to voluntarily report cases. They are not doing. So a doctor's office report 2 cases of measles. A nursing home reports an unusual number of older patients with unexplained rashes. So they are getting the surveillance without getting actively involved what is happening. And the just opposite will be active surveillance, where these people are becoming proactive. They are getting into the community and they are finding out what is happening, or what they collect the data. So here they require intentional efforts. Maybe they call up all these clinics or the doctors or the healthcare facilities, they are actively involving in collecting the data, being proactive, coming out of their comfort chairs or tables, whatever they go into, and find out what is happening. That is active surveillance. So some examples will be to conduct regular health service. People will be coming out, going to a particular area and take health service. It can be a usual community, or it can be certain hospitals. Uh, for example, they may have plotted out certain hospitals, and they will be like every day going to one or the other hospital and take a weekly collection. Like that, they can do. Or they can do screening programs. Now, screening program is one of the chapter we have to deal later, but screening is like to screen out. We do certain mass screening programs for the population to find out who is having a disease even before they start showing symptoms. For example, if I don't know whether any of you have done that as a part of promotion of our own clinic or hospitals. People do that, the hospitals or the personal clinic, whatever. So they will be selecting a particular area where a large number of people will be coming. Either it can be a shopping mall, or they may go into some public areas like a railway station or bus stand. I mean, an area in which a large number of people can come, or even the schools. The schools they can go, and they will be conducting certain small investigations. Like if it is, you can just monitor the BP of the people when you're doing some community activity. They just you can just monitor the BP of the people, and then you are going to get a set of people who are having high BP. And likewise, you can also using a glucometer test the blood sugar of the patient. So, or even children. In case of children, just a mere otoscope is enough to view their inside the ears to get to know, or even some kind of eye testing. You can make the people students to read that chart, whether they are able to read or not. So to understand whether they have any vision problem. So like that, simpler test you can do in a population to find out people who are having some troubles, but they have not yet realized that they are patients. For example, some of the person is having a high glucose level, but he had never known. He never knew that his glucose level is normal, because in the initial stage there won't be much symptoms, or maybe just mere tiredness, and the person never realized. So while you were doing some a screening program like this, or a health checkup like this, people just come to you and they are accidentally getting to know their blood sugar is high. So even before the symptoms are produced, you are getting to know that the person is having diabetes. So you are giving better treatment. So this is like a screening program where we find out the people who doesn't have the disease. And if you remember the iceberg, the tip of the iceberg that we discussed in the epidemiology in one of the earlier PPT, I told you the tip of the iceberg, it always shows the clinical diseases which are having clear manifestations. But epidemiologist is always involved with the submerged portion, which is not visible. And that submerged portions will be those people who don't have any symptoms. They may be mere carriers, or they may be in their pre-pathogenic phase. They have not yet developed, not pre-pathogenic, early pathogenic. Something has happened in their body, but the symptoms are not being shown off. So the epidemiologists are more involved in those people, because the vast number of patients who don't exhibit any symptoms are in that submerged portions. So this screening program is one of the best method to find out those people who have not yet developed symptoms but are having disease. So earlier we diagnose, we can give earlier treatment for them, and then we can prevent them going into complications, or even we can cure the disease. So that is the importance of screening program, and it is a part of actually active surveillance. So they can do for that. Then they can establish sentinel surveillance sites. Sentinel surveillance sites means They may not be going to every hospitals, but they may have selected one or two of the selected healthcare facilities, and they will be going to that area to collect their data. And also contact tracing and case investigation. Contact tracing is they got like what happened in case of COVID initially. They have one patient and then they make a tracing of which places he had gone. It was called as mapping and all at that time. Even tracing which places he had gone, which all people he had met, had a close contact with, and then to monitor them. So that also can be done. So whenever there is an active involvement by the epidemiologist in the community to get a data about the disease that is happening, then it is called as an active surveillance. Then there is syndromic surveillance. Syndromic surveillance, as the word indicates, they are not waiting for some confirmation. They go for the syndromes. Syndromes means some set of signs and symptoms. For this purpose, actually, they can even use the people, non-medical people like ASHA, ANM, etc. So, for example, in India, where there is ASHA and also ANM workers, what they do is ASHA people are given some training that they have to report. They're supposed to go every house at least weekly, or there is a duration for them, and then continuously monitor. So if they are finding a baby who is having direct symptoms, even before for diarrhea may not be, especially in rural areas, in the village areas, mothers may not be taking the baby for a diarrhea to hospital. They may be trying to solve it with a home remedies, something like that. Uh, but we don't know what exactly this direct symptoms of that baby is. It may be just viral, or it may be as serious as like a cholera. We don't know. So these people, the ashas, will be given instructions that they get to know some direct symptoms. So they don't know whether it is a mere food poisoning that happened with the baby, or a very serious cholera. But if there is diarrhea, let the doctors be known, like the public health department where they are working, they should inform to them. Likewise, if a child is showing fever and cough, because that can be a sign of pneumonia, so or even tuberculosis. So fever and cough a baby is exhibiting, then they have to inform to the nearest public health clinic, and also prompt the mothers to go to the hospital as early as possible. So here the ASHA people, they don't know whether it is pneumonia, whether it is cholera. They are not waiting until the confirmation is coming up. They just collect certain symptoms. Uh, they are given the guidance like if these symptoms are present, then they should be, I mean, the public health department should be let know. So according to that, based on certain syndromes like 2 or 3 symptoms they see collectively, they don't wait for the confirmed diagnosis or anything, but they just inform to the public health department. So this type of surveillance is called as syndromic surveillance. So we can see in active and passive, mostly it is the doctors that is involved, but in syndromic surveillance, even non-medical persons are involved. So it is a real time or near real time collection of data, like what is happening now. They are not waiting for the confirmed uh, beforehand collection. It is a symptom based monitoring. I explained that to you. And it is belonging to broad data sources, like from the emergency department, over the count medication sales. So you can get the information even from the pharmacist, school absenteeism, social media post. Some people report about some cases in their area. So from various sources, we get to know, we can do this syndromic surveillance, and it is not based on any confirmatory or lab investigation final report, but based on the symptoms, and then they can take ready action upon. So this is about the surveillance, the 3 type of surveillance. And now investigation and management of an outbreak. So what happens when there is an outbreak? What are the, how the investigation is done, how the management can be done. So you can also write this answer with what happened during COVID-19, the process that was done during COVID-19. So when there is an investigation, the main objective is to define the magnitude. When COVID-19 came, how many people are affected, how many people are dying, how many people are hospitalized, uh, and how many days they are hospitalized. Like that, we can understand the magnitude by investigating an epidemic. And then also we get to know the conditions and factors responsible for the occurrence of the epidemic, why that happened in that particular population, whether it was lack of hygiene or the food practices, whatever be that disease, what is that condition and factors responsible. And to identify the causes, the etiological factor, the sources of infection, mode of transmission, etc., so that we can control that epidemic. So all these things were happening in COVID-19. They were finding out the people who are having disease, then contact tracing, like whomever they have contacted with, wherever they had gone, and then they were trying to find out how this is transmitted, whether it is air transmission or contact transmission, what is the exact source of transmission, and that's how they came up with the idea that it is transmitted via droplets and maybe contact also, so that we keep at least 1 meter distance from the people. We start using mask. So all these measures they told means the public health department asked us to do, because those were the method of the transmission also. Then to make recommendations to prevent recurrence. So these are the objectives to do a epidemic investigation. And there are some steps for these investigations. Though we have gone one by one, most of these steps can be done concurrently. So first we have to verify the diagnosis. We see some symptoms. Though we are already told that syndromic surveillance is also a method. So in syndromic surveillance, we are not verifying. We are just collecting the symptoms and then we are actively looking upon that. But before we do something, we have to verify the diagnosis, not just syndromes or the clinical symptoms. We can start the treatment. We can start the treatment of the patients even without verifying the diagnosis. But if we are going for an epidemiological investigation, we need to verify the diagnosis, what the disease the person is having. So we have to verify, confirm the existence of an epidemic, define the population at risk, who are more at risk, who are more prone to develop this disease, rapid search for all cases and their characteristics. So whomever the patients are, just monitor them and what all symptoms they are showing. Collect the data and then do that data analysis, like how many people are affected, all those things. Then formulation of a hypothesis, testing the hypothesis, evaluation of the environmental factors or ecological factors, further investigation of population at risk, and finally writing the report. I'm not going into detail of each of these steps because it comes under the research methodology also, but this is somewhat an idea of what we are doing or what the public health professionals do when there is an outbreak of an investigation. Oh, after writing the report, there should be one more point, that is disseminating the data. I should include now itself, or I will forget. Disseminating data is actually very, very important. Then in case of epidemic management, there are certain key strategies. You can just go through that: surveillance, isolation and quarantine, contact tracing, communication, community engagement, like how people also become part of it. No public health practice. That's another rule you have to keep in your mind. no public health practice is going to be successful unless there is a engagement from the community. We go into a community and we try to do anything, being a public health professional or medical professional, nothing is going to change unless the people are involved as a part of it. Unless they feel there is their security involved in it, it is their need. Unless they start feeling that, we can't do any particular thing. We need the community engagement. Then the healthcare readiness or responsiveness, resource allocation, public interventions, especially in the form of promoting hygiene maintenance and also vaccination, travel measures in case imposed travel restrictions, coordination, evaluation, and doing the collaborative actions. So this will be the key strategies in a case of epidemic management. Now, when we go to the homeopathic management, we follow along with the other, we follow the medicinal, that is the genus epidemicus. And I kept over here, but can someone of you say me what is genus epidemics and how we do that?
The remedy that uh, covers uh, covers the specific symptoms of the totality of that particular disease that is able to cure the majority of
Mhm,
persons.
mhm. Okay, so that has been explained, I think, in the 102 aphorism of Organon of Medicine, where Hahnemann says that we need to have a lot number, in case of epidemic, a lot number of patients. So they will be showing some similar characters because there is no time for us to wait for individual patients and then see their individual characteristics, because epidemic, it is coming from a common source and it will be having, there will be individual symptoms, yes, characteristic symptoms, but there will be some common symptoms also. So we need to trace down that common symptoms and then we prescribe the medicine. So that's what it has been told, that there will be a symptom pattern, a common set of symptoms, and we have to find a remedy suiting to that set of common symptoms. And we can do it like a collective approach, administer to the affected group. And sometimes it may not work because in case of prevention, yeah, but maybe if the person is already having some individual factors or some serious disease, we need to go for the individualization. Then sometimes when the symptoms changes, or when a large number of people comes, or are they are affected, then we see some pattern difference, then we can go for other medications also. uh, and collaborate with the experienced homeopaths. In case if we remember, I mean, I'm not sure about what happened in Malaysia, but in India, initially it was told that better to give COVID-19 arsenicum album initially itself, because of the symptoms that it was creating panic among the persons, and also it was with respiratory complaints. So people, I mean, the Janus epidemicus initially advised was Arsalb itself, but then there were other doctors like Rajesh Shah, I think, in Bombay, and also the person with all, not with all cars. Oh my God, he passed away because of that disease itself, COVID-19 itself. He was the proponent of predictive homeopathy in Bombay. And I'm not remembering his name. So
Prabhu
he,
Vijayakar.
yes, Prabhu Vijayakar. So he also came up with other set of remedies, and they had remedies like bryonia, then influenzinum, uh, eupatorium, because some of the people were showing the body pain, and then gelsemium. Because of that, they were coming up with other set of remedies. And I think Profil Vijayakar, did you mention sepia? You remember, Vinod? You know?
No, not sure of the remedies he mentioned.
Yeah, he mentioned sepia, I think, for this condition also. But after that, um, And he had his own reasons to specify as sepia, why sepia has to be given. Because he was connecting it to electromagnetic radiation. At that time, it was told that the 5G radiation is one of the important reason. It is interfering with Earth's magnetic. I don't know. I don't know much about these things. But because of that, he suggested sepia, the medicine, to be given. But even then, that was creating a problem among the WHO and our allopathy teams, because they were confused with what the medication to give, and we have came up with our set of medicines. So they just wanted to prove that we are wrong, and they have never accepted homeopathic uh, treatment. So they were not ready to accept. And in India, there is a research institution, CCRH. So, so the CCRH is the Central Council of Research in Homeopathy. So they had to end up with one medicine. So even though these doctors were coming up with other medicines, whatever I told now, the government o- of India, which was supporting the Ayush, they wanted to promote only arsenicum album. And even that, it was not promoted as a genus epidemicus or a preventive measure, but it was given as a what is that, immunity booster alone. We were not allowed to told say it as a preventive medicine. But when I say this, I can say, I mean, that was a collective approach, not from our part. The whole allopathy or the modern, so-called modern medicine, they were acting against us. But I remember one of the instances when I was working in one public health project. So that had a associated allopathic hospital actually, and they had a public health wing. So I was working in that public health wing. They had a project to control diabetes mellitus. So I was the program manager of that project. So one day I was sitting over there, and almost all the doctors who are working in that hospital, they were I mean, they were, their background was MBBS, MD, MPH, most of them. So one day I was on leave, and the next day I went there. One of my colleague told that so and so doctor came to meet me, and I was so surprised why this doctor came to meet me, because he was not in that project. So I before I went to meet to him, he again came, and then I asked what is the matter, because he is an allopathic doctor, and we are not expecting that to come to our this public health department. The clinical department in that hospital and the public health department, they go in different or parallel ways. So what he wanted was that he got into in a contact with someone who was diagnosed 1 to 2 days later with chickenpox, and he wanted the preventive for chickenpox. So he remembered when he was a college student. So remember, he's a MBBS MD person, okay, MD MPH. So once when he was a student, MBBS student, then also he got into contact with someone who was having this one chickenpox, and at that time, some homeo doctors had given him one of the, not one of the, it's only one preventive for chickenpox. You know, it is variolinum itself. So they have given him some medicine, after to which he didn't develop chickenpox. So he came to meet me because he was in close contact with someone, and the next day the person was diagnosed with chickenpox, and he wanted to have that same medicine, that same preventive. So that is why he came to meet me. So because I didn't have any medicine, I was staying at a hostel at that time. I didn't have a clinic at that time because it was, this project area was away from my home. So I just gave him the name of the medicine and asked him to buy from the pharmacy. So I was quite surprised. Like, though he is MBBS, MD, MPH, he wanted that preventive medicine of chickenpox. which he had eaten very years before when he was doing MBBS. So this shows that there are many people among the allopathy which believe that there are preventive medicines in homeopathy, and definitely they act. But the thing is, when it comes to a collective thing, they can't open their mouth. When it is in a group, they can't support us because it will be against their profession or their ethics, whatever. But some people still they do, some allopats. So yeah, so the I just told that the genus epidemics, what happened when people like COVID came, we were just suppressed. We were not even allowed to say the name preventive for COVID-19. We had to use the term immunity booster. In a way, all our medicines are immunity booster. We are not doing anything. Our medicines are not doing anything. It is just boosting up our vital force, or in a way, our immunity. That's what is being done. So it is not just ourselves that is an immunity booster put in short. It will be all our medicines are in a way or other immunity boosters. Still, we are not allowed. And then there are people who admits and accepts that there is preventive measures or preventive medicines for certain diseases in homeopathy. So that is about epidemiology in short. Um, so the second and the third sections of this case management and homeotherapeutics. I think in the last class I have sent you this PPT, but I will send it again today because some of the PPTs, especially the passive, active, and syndromic surveillance, this slide and all I have changed. So I'll be sending it again for today. So that's about the second and third. You have any doubts regarding this topic?
No.
Okay. So I'll start with the next topic, that is section 4 and section 7. I will do it together. So this PPT is section 4 and section 7 together because it says about the social sites. You're seeing this PPT right now, right? Section 4 and section 7, social science and medicine. Are you? Let's start with this. So after 2 and 3, I think it is 4 and 7 that is more important. And then in section 6, we have another important, that is screening. And some portions from there. And other portions, I don't know, like immunology. You already know about immunity. You can take a class for immunity for me. So I'm not sure whether you want me to take that portion of immunity. I think you're already learning immunity in what is the other one that you're doing, study of patient and study of diseases. You're learning immunity over there also. And then the section 5 is emerging and re-emerging. Some of it we have already done in practice of medicine. Cholera, tuberculosis, AIDS. And AIDS, it is also coming under study of patient and diseases. So many repeating portions are there from the previous semester and the current two modules that you're doing. The other things we can easily skip. In this one, the case management and homeotherapeutics after 2 and 3, 4 and 7 will be more important. And also screening. Screening is also part. So why I did this connection together, like social sciences and qualitative and quantitative research, because quantitative research or qualitative, the research methodology, it actually comes under the subtitle social science research methodology. So that is why I club both the portions together. So under social sciences, you need to learn the relevance of social science in medicine, the psychosocial and cultural determinants. Some of it we have already learned when we were doing the history, the natural history of diseases, the concept of health, the environmental concept, ecological concepts. We have dealt over there. It's just some repetition from the. Then what is the social security and also social science research methods. And from there, we will go to the qualitative and quantitative research. And here, they have given importance to questionnaire design, FGD, focus group discussion, and in-depth interview. So this is mainly from the qualitative part. So even in this PPT, I have given importance to the qualitative research methodology only. Quantitative, I have not given much importance. Now, what is the relevance of social sciences in medicine? Now, this is something, even though it is asked as a long essay question, you can write from your own what is the relevance, because we have already dealt with it. If you now observe, we can see a lot of social scientists in medicine, or a lot of people who do public health. They comes from the social background, like the camp. If you do MPH, you don't exactly have to have a medicinal background. You don't have to be a doctor. There are colleges which allow people from different uh, spheres to come and work in the public health department, like even uh, people who are doing journalism, or anything, even language or anything that was a community related thing. Those people, even though they don't have any medical background, they could do in I mean social scientists to be a part of medicine. And even here, if I didn't do MPH, I would have definitely become very strange why these people are involved in this kind. For example, some of our PhD graduates, the supervisors they have, the supervisors are in the social science department. So if I had never done MPH, I would have wondered what these people are doing with the PhD in case of public health. But now, after doing this public health, I know people from different arenas can be a part of medicine. It is not that the medical thing they are involved with, what is happening with the virus or the bacteria, the lab thing, they are not involved with that. But the other determinants of the health, the environmental influences, the social factors influences, the cultural factors, and that the social science department also deals with it. And when we learn diseases like especially tuberculosis, AIDS, all the examples that we have seen, it is not one organism and then it results a disease. It's never, our diseases are like that. The germ theory of disease say like that, a linear relationship, but we have seen that that linear relationship, the germ theory of disease was just the initial idea. But then from there we had moved up to the web, the causation, or the web causation for chronic diseases. A lot conditions, risk factors, and how it is influencing the disease. So in that we have seen even our personal habits can also influence. So from that knowledge itself, you can write the whole essay about. And still, I have to repeat, I have to say something. So this is the relevance of social sciences, because in our health and well-being, the social, cultural, and behavioral factors do affect. Social is what we have to follow according to the society around us. Cultural, the methods or the cultural practices in our own community. And behavioral is our own behavior, the personal behavior. So this is very important in case of medicine. With this is important because it helped us to know the health disparities, because there are factors like race, ethnicity, socioeconomic status, gender, etc., which can increase or decrease the frequency or intensity of diseases in certain population. It is not that every population or every people, every gender, every age group, they're having same risk of disease uniformly. There is nothing, there are disparity. So that disparity will be varying, and according to the, I mean, across the population, and so the disease also. So we need to know about the race, ethnicity. Even when we describe the disease, we say some of the disease is more in African population or American population. We say like that, some race or ethnicity. Likewise, we say about the socioeconomic status also, and the gender. So while we do this social science only, we will understand why certain population experience higher rate of disease. Then patients' behavior and adherence, their attitude, their beliefs, and how they can be motivated to adopt healthier habits. This is very essential for designing intervention and treatment plans. Uh, so when we know what the cultural practice a particular group of people are following, then only we can try to motivate them. When it comes for the weaning practice, some of the culture, they may be having a different style of weaning. Weaning is something like when the child, the baby, after 6 months, they should be given solid food, started to give solid food. Until then, it is only the breast milk exclusively. After that, according to the WHO, we can slowly initiate solid or semi-solid food for the baby. So that practice of introducing the solid or semi-solid food for the baby and slowly stopping that exclusive breastfeeding. The technical term for that is weaning, WEANING. So for some culture, the weaning practice will be very different. They will be giving only particular set of food for the baby, but that may not be nutritious enough. So maybe the baby will be having some malnutrition condition, so we have to know about their cultural practice, then to motivate them to change their practice. Otherwise, it is not easy. Then the doctor-patient communication will be very effective if we get to know about their practice. It is very essential to know for their to build trust to enhance health outcome. So we should know about their cultural, social, and psychological factors also. Then for we should know these population disparities, etc. When we are formulating the public health policies. So when the government is setting some policy, the government should be knowing to whom this policy should be addressing more. Because always when we if you have learned economics somewhere in your course, you will be always saying the first principle in economics will be the resources are very less, so we should be judiciously using it. So wherever we go, we'll see that term in economics, resources are less. So for that, if the resources are less, we should better manage it, we should better utilize it. So the public health policies or the government policies will be favoring to the people who need it more. And to know who people need it more, we need to know the population that is affected more. So for that also, we need to understand the social background of a disease. Then for health education and health promotion, as I already told, only if we know what they are practicing, we can try to motivate them. So this is one of the conceptual framework of the WHO, which show the importance of psychosocial factors. So psychic and also social or the environmental factors and also the cultural determinants. So you can see how formulated it is. And probably maybe you already know, whenever we are doing some research project, especially if it is a review article like this, if you want to explain or write a research project or a dissertation project also, a secondary from the data. Uh, this is not a primary data collection. So you need to have a conceptual framework, and then you are going to explain that matter using this conceptual framework. So this framework will be indicating the importance of all these factors. So you can see how the socioeconomic and political factors, including governance or the policy. Governance will be what type of government it is, whether it is a monarchy or a king rule or a democracy, and the policy, the health policies regarding in the economic level, the social and the health level, the budget that have been assigned by the state for the health, and the cultural and the societal factors, how it is interacting with the social position, education, occupation, income, gender, ethnicity, and then the societal things, the social cohesion, psychosocial factors. And ultimately, all this leading to distribution of health and well-being. So these are the social determinants. So it is just the model or the conceptual framework of WHO, which indicate the importance of these factors in determining the health. This is under one. I just put some examples of the various framework that is used whenever we are going to describe the social determinants of health or the determinants of health per se. So you can see in the center, it will be the individual factors like the person's personal factors like his age, sex, and the constitutional factors. Then there is social and community network, how that is managed, and general socio-economic, cultural, environmental. So in between there will be the living conditions, support from the society, how is his relation to the society, to the colleagues, and then what is his working in condition, and also the area where he is working. Sorry, not the area where he is living, like the water and sanitation in that surrounding area, whether it is overcrowded or not, what are the healthcare facilities available, the housing style in which he lives, because everything of this can affect the health of the human being. So this is another conceptual framework that is used. So the social determinants, how we are affecting, we need the social support. Whenever a disease is there, we need a support. It can be financially, or it can be just emotional or instrumental assistance during some stress, illness, or life transition. No human being, because human being is a social animal and we are in the society. Though we say that we can live independently, you always know it is not always possible. It's not always possible. Some of the other time we have to have that social interdependence. So that is very much required in conditions of stress, illness, or life transition. Socioeconomic status, we already know that people in higher economic status generally will be having a better health just because they have better access to healthcare, and they will be having healthier lifestyle and improved overall health outcomes. Then education and literacy. People who are having better education, they will be having good health behaviors and also better health. Employment and working condition, because that adds into the stress of the persons. So the job insecurity, high job demands, law control or workplace stresses can also influence the health of the person. The social environment, then health beliefs and behaviors, just the repetition of all those things. You can read from here. Then this is the image which depict the impact of social factors on mortality. So here you see that more than 50 percentage or half of the reason for the mortality is of that single individual behavior, where the reason is smoking, obesity, stress, nutrition, blood pressure, alcohol, drug use. And except maybe blood pressure, which we may find a genetic basis for that. All the others are due to their personal behaviors. So how it affects the mortality, you see that. Now, the influence of social security. Social security means the assistance, especially in the form of finance, like certain insurance policies. So, this social security, it offers financial and social assistance, including healthcare coverage and access to medical services. It should be equitable, like programs like Medicaid and Medicare or any insurance policies, so that people will have a fair healthcare access, reducing disparities. But even though I write the sentence like this, you might be already knowing it is not easy. Even this Medicaid, Medicare, or any health insurance we say, it is based on our income also, everyone's income, and according to the premium that we are paying. And if it is by the government, I think it is Germany may be having this uniform health coverage, but then they are taking a lot of tax for that by the government. But many other countries, the government support uh, providing this healthcare insurance is very less, or it depends on our premium. So it doesn't give an equitable access, but some of it, like when if I say about India, um, there are government's health insurance policies, which is mainly helping the people who are below poverty line. So if you go with that certificate of below poverty line, there is a minimum annual income. So if that annual income is less than that, You go to the related revenue officers, they will be giving the health card, and that health card they can access better treatment in the government hospitals or even private hospitals, but the set private hospitals, not all private hospitals, for a set amount that is being set. When we go in India itself, so this part of BPL is being covered, I can say that. But when we go to the higher section of people in India, the rich people, they don't need this because they will be having their own personal health claims, the private ones. So, and also they are filthy rich that they can manage. But then there is a vast section, vast population in India who are belonging to the medium income one. So there is a upper middle class and lower middle class. And if I go for the demography, the people in India will be a large number will be belonging to this lower middle class. They are not below to the poverty line. They are not the upper middle class or the filthy rich, but majority of the people will be in this lower middle class. And the social security provided by the government for this lower middle class is comparatively less in case of India. So it is always the people who are in this lower middle class in India that is affected because according to the government criteria, they are above poverty line. But when we, so they are not going to get this government facility of social insurance, and these people are not rich enough to pay the very high premium in the private insurance. So this section, and that's the worst section in India, they don't get that enough social security. So it depends, it varies from country to country how the social security is provided. But if it is provided uniformly, that every population have an access, then it is very nice. It will be ideal, and it give equitable access to the health programs. It gives the financial protection. So it helps the family from facing financial hardships whenever there is an unexpected health expense. Then there are also the government which provides disability benefits. Not all the governments or not all the countries, but based on those certain countries. So here is where the health policies which will help. When we say that the social security or the in the initial slides we are saying about the policy, the health policy set by the government. This is the thing. Like what I told you in India, okay, the government is supporting BPL people. Very good, very ideal. But what about the large population who is in the lower middle class, who are not in the BPL class or the below poverty line, but not rich also? What government is doing for them? So the policy is lacking over there. So the health policies also matter. That is why what the government is doing, it definitely matters. So some governments they do give disability benefits, especially the Western countries, I think, and that's a great support. Then maternal and child health support will be given. Some countries will be giving that. So put in short, the policy coordination, comprehensive social security require effective coordination among stakeholders. So this social security is pivotal for healthcare, providing financial support and healthcare coverage. It will help the vulnerable groups and that will contribute to overall well-being and reduce disparity. But still, if it is not uniform, then also there will be some kind of disparity. So that's the relevance of the social science in medicines, why we need to learn about this social science or the role of social scientists in medicine. Uh, Now we go towards the research methods. So what is the meaning of research? Research in common. Research is actually when we say we pronounce it actually research, but it's actually research. So something that is again and again searched. So that will be research. So research in a common parlance refers to a search for knowledge. One can also define research as a scientific and systematic search for pertinent information on a specific topic. We go on, go on, go on. Every research article, now that you are doing assignments, you know that every research article or every research journal, it will be ending with more research is required. That's like a default sentence. This experiment have been done only in this much number of people, or the survey was done only in this small population. So to have a better idea, we need to increase the size of the sample or whatever. Every research, that's a default sentence actually. So it will be a continuous process. There will be a lacuna in that research done until then, where we find out the literature gap, and then some other researchers try to continue with that. So that's why one topic we take, we can have many articles on it. So that's a continuous search to add on to the information on a specific topic. So research is an art of scientific investigation. We have two approaches, the quantitative approach and qualitative approach. So quantitative approach, quantity. So quantitative will be the word over there, the keyword over there will be quantity. And in general English, when we say quantity, it indicates some size or some number. When we say, uh, I mean, you're going to purchase something from a grocery shop, you give a quantity, buy 1 kilo of sugar. So you're giving a number, a quantity is being given, or 2 packets of noodles. So a number is given, a quantity is given. So that's the same idea with regard to quantitative approach. You're giving a number, some numerical thing are coming over there. So wherever numerical things are coming, that will be a quantitative research. We can do some of the classification will be experiments, simulation, and inferential approaches. Experimental will be like what you do in a chemistry lab or biology lab or whatever lab what you're doing. Whenever we are going into a lab, there is a measurement we have to follow. We can't just put anything and everything. Everything will be having a particular measurement. When we in the especially in the chemical lab you go, when they say 2 ml of particular alkali to be added, it is exactly 2 ml we have to add. We can't reduce it, or we can't increase it. That measurement we have to maintain. So it can be the quantitative approach. There will be experimental when we are giving some medicine, or the animal experiment or anything that will be a number related, can be a simulation, uh, where we are trying to make a model and then do it, but then also there will be some number involved, and inferential approaches where we have some statistical data, and from we are coming into certain numbers and interpreting the data. So these things, where the number is dealt, that is the quantitative approach. So what is qualitative? So the key word over there will be quality. From quality, the qualitative. So what is quality? Uh, when someone asks you what is your quality, you are not going to put it in any numbers. You are going to give some word or some description to that. You're going to mention about the good and bad in you. There is no number, but certain features. It will be some words. So that is actually quality. Here there won't be any words. There won't be any numbers, but there will be some attitude, opinion, and behavior. So whenever you have certain words which indicate the quality of that thing, it will be a qualitative research. And whenever it is a number we are mentioning, it will be a quantitative approach. So when collecting and analyzing the data, quantitative research deals with number and statistics, while qualitative research deals with words and meanings. Both are important for gaining different kinds of knowledge. It depends upon our research, what we are trying to find out, which will help, um, uh, which will say what type of research is important. We can never say that quantitative is more important or qualitative is more important. Both are important. It depends upon what we are learning. If what we want to learn is the prevalence of um, AIDS in a society, we need to know the prevalence, which we means we need to know the number. So obviously we need to know about the, or do we have to deal with the quantitative approach. But if you want to find out why tuberculosis is seen in such a high number in a particular society, we can't have any numbers. We need to find out the reasons, and that will come under qualitative approach. But when we say that, how did we understand that such a population was having a high number of cases? We got to know that from the quantitative research. So we did quantitative, we saw that high population, that particular population is having a high prevalence of TB. So quantitative is important though, and then we want to find out why it is happening so. So we come to the qualitative. So there is nothing like quantitative is more important or qualitative is more important. Both are two different approaches, and it depends upon what is the thing we want to study. So quantitative research expressed in numbers or graph, it is used to test or confirm theories and assumptions. Like in case of quantitative, you will be studying in detail in the research methodology in the next semester. But in quantitative methodology, you will be always having a hypothesis. And with numbers, you are going to prove or disprove that hypothesis. That is why it is called that it is used to test or confirm theories and assumptions. So you put on a theory or a formulate a hypothesis, and by numbers or statistical analysis, you are going to either prove or disprove that. When it comes in qualitative, as we already saw, it is in words, and it is to understand concepts, thoughts, and experiences. There is nothing to prove or disprove over there. It is just to know about that community idea. Like in case of tuberculosis, I say that tuberculosis is more seen in overcrowded housing. That's my hypothesis. I'm saying the null hypothesis. Hypotheses are also two types, null and alternative hypothesis. So I'm not getting into the detail. Null hypothesis will be something saying no. So, or there is no difference like that. So I'm saying my null hypothesis that there is no difference of tuberculosis between people living in a high socioeconomic status and people living in a low socioeconomic status. And my alternative hypothesis will be just opposite. There is a difference. There is a difference in the incidence or the prevalence of tuberculosis in high and low socioeconomic. And in case of to prove or disprove this, I have to have some numbers. Then only I can prove or disprove. And in certain conditions where I'm going to learn about their attitude, their knowledge, like what the people is thinking about tuberculosis in that particular area. I can't put a theory. I'm not someone to put, not me. A researcher is not someone to put a hypothesis on someone's mentality. We can't say like the person will be thinking like this. That is null hypothesis, and the alternate is the person is thinking in another way or the opposite way. We can't put like that because it's an individual or a community knowledge, beliefs, and all. So there is no hypothesis in case of qualitative research. There is nothing that you are going to prove or disprove over there. No numbers being analyzed. But here you are just trying to understand what is happening to gather deep insights on the topic that are not well understood. So here there is nothing to prove or disprove, to reject or accept. It is just to know what is happening, to understand in deep or why it is happening. And the common quantitative methods include experiment, observations, and surveys, and it will be usually closed-ended questions. And closed-ended questions, you already know, the yes or no questions. Whenever we formulate yes or no question, where the person doesn't have any option to give another answer. Like some questionnaires will be coming, like, are you a smoker or non-smoker? And you have options of only yes or no. Sometimes they gave some options like occasional. Then it is fine, you can put occasional. But if it is not that, it is only yes or no. It is either yes or no. You don't have any option to choose any other thing. So that are closed-ended question where the person who is giving the answer, they don't have any other option than what the person is saying. I have to select one from that. So in quantitative research, it will be always closed-ended questions because we have to get the numbers, and the numbers should be very much confirmed, not like a ambiguous number, which is like not sure about it. We can't do. We are going to do a statistical analysis, so we have to be very sure. So they make that questions in quantitative research closed-ended, but in qualitative, because it is going to do the qualitative analysis or like what they are thinking, the questions will be always open-ended. Well, the question will be what you think about it. So the person can say anything. The person can say even in a one word that nothing particular, or the person can say give a detailed essay on what they think about it. So those questions in which the person can open up their heart and they just don't have to confine with yes or no options, that are called as open-ended questions. So that will be the basic difference between quantitative and qualitative research. And the data collection method, how do we collect data? For the quantitative, we can go for survey, the questionnaire, etc. As we already told, it will be closed-ended question or multiple choice question, and it can be distributed online by an email or post to a person, or just go meet the person in a public area and then give them the question, ask them. I mean, you can't just give them. We need to ask them, are they ready to participate? And consent form should be the, especially if you are doing the PhD thing, for the ethical approval and all, you need to have a consent. So make the person consent, sign the consent form, and then give the questionnaire and get it filled. So like that, you can have a survey and we will get the numbers, or you can do it in the experiments, the lab experiments I told you, or the observations. Just observe the people. And in qualitative, the qualitative, we can go for in-depth interview, the focus group, the ethnography, and literature review. So in in-depth interview, you are going to question a particular person in deep. In deep, you are going and asking the question to the people. And it won't be like a fixed questionnaire with yes or no questions. It should be very open-ended. And focus group discussion, you are going to select people in between 6 to 10. There's some criteria for focus group discussion. People should be between 6 to 10. It shouldn't be more than 10 that you are not able to moderate all the people, and it shouldn't be less also. So between 6 to 10 should be the number of the people. They are brought together. They are given some questions and they are just asked to discuss. Then we have ethnography. Ethnography is like you want to learn about the ethnic features of a particular tribal community. Suppose you want to learn some tribal community, and then you're going and living with that tribal community for 2 months or 1 month, whatever. So that type of study where you're going and you're not just observing, like you're living with them. You're uh, when we come to this part, the observations in this quantitative, like you will be just observing them, what they are doing, what are not they doing, like that, just observing. Sometimes people may be knowing that you are observing them. Most of the times people don't know that you are observing them, and then you collect the data. But in ethnography, you're going to live with that population for 1 week, 2 week, or whatever. Live according to them, what they eat, when they get up, all the cultural practices. So that will be a ethnographic method of collecting the data. It can be also a literature review from the published work or the earlier one. But here I will go with the more in case of in-depth and focus group. So in-depth interview, like one of the class I told you, you are going to deal with a person in personal for like about 30 minutes or to 40 minutes, not more than that, and then probe in detail. So in depth, as the word indicates, it's going something deeper. If it is a well, if it is a well, just imagine that you are going deep, deep, digging deep, 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 deep. So when you have to go and dig deep in, that person whom you are interviewing, he or she should be some kind of expert or some kind of person who had experienced it most. Say, for example, that day I told you the homeopathy. When you want to learn about homeopathy or do the in-depth interview, you're either going to the expert, a homeopathic doctor, and go deep, 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 deep into that topic, or you can go to a person, a patient who had been cured with homeopathy. So, in case of in-depth interview, you are dealing with people who have the ability to give you more factual reasons, not factual, it should be numbers, more detailed explanations or more expert opinions. Someone who had experienced it a lot. So those are the in-depth interviews, something very rich you will be getting from that single person, because you are spending 30 minutes to collect data from a person. You want to know about homeopathy, and there is no meaning that you spend 30-40 minutes to a person, a layman person, who hadn't taken any treatment in homeopathy, or who hasn't studied homeopathy or know about homeopathy. There's no meaning in spending. So you need to have someone who's either an expert in that subject, or someone who is closely involved in it. Um, if you're learning about sexual abuse, you can be, there's a person whom you're questioning in in-depth interview will be some researcher who had done a lot of study in this topic, or people, the NGO people who are involved in this, rescuing the people from this, um, if it is a brothel, rescuing those people. So they have dealt with a lot more cases. So to those people, you can do in-depth interview, or you can do to a rape victim or a survivor. So people who can give valuable insight to your research. Those are the people in any way experienced, or having more knowledge of. Uh, uh, those are the people to whom we do the in-depth interviews, that we get something out of it. And focus group discussion, it will be the same example of well, digging the well. It will be, I would say, you dig the well not deeply but widely, like in a wide thing. So in in-depth interview, you're going deep, 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 deep. But in case of focus group discussion, it will be wider. You are going. You are going to wider or widen the digging of the well. Not deep enough, but just the superficial widening. What a large section of population are thinking about. So these people may not be experts. Also, they may be the general population. So the question formulation for the in-depth interview and focus group discussion, now you understand it will be different, because the section to whom you're questioning are different. So one is expert, or they have experienced it very closely. So you can formulate the questions in that manner, and the other will be just superficial, their general ideas, what their feelings or what their thoughts are. That will be the focus group discussion. And in in-depth interview, you ask the, I mean, it starts with a introduction, and then you slowly from the start, like a interview of a political leader. You start with general thing, and then you go into slightly specific, and then the questions may be formulated in a controversial manner, or some controversial relationships with other ministries, etc., or other political parties. So like that would be a best example. And focus group discussion will be more regarding to the people, like how is the ruling of this party that is going. So different people will be having different ideas. Uh, if the government policy is supporting more towards the business people, and you're doing the focus group discussion among the business people, they will be saying about, oh, the government is so nice because all the policies are favoring to them. But then you take uh, the general opinion of the people about the government, who are belonging to this lower income section, or the working population who doesn't get much, who are in government job itself, but they are not getting much salary. The increment has not happened since years. Um, then they are going to give a different opinion. So the focus group discussion, there should be 6 to 10 people, and you should be the moderator. You shouldn't allow them to discuss some other matters. like ask a question, one person can say, the other person can add in, like that it will go. But the moderator should be very careful that the people are not going for their own individual talk in between. So that is why we always say to limit the number of the people, not more than 10 and not more than 30 to 40 or more than 45 minutes. That should be the average timing. So now I think you might be understanding what type of questions you formulate, and this should be open-ended, of course. Then there is another important thing I actually should say. In quantitative data collection, there is something called a structured questionnaire. Like you already prepare a questionnaire, and you can even do a testing before to that. Before you go and test in the society, you can do a preliminary test for that, whether the questionnaire is okay, people are able to answer, whether you need to change the question, you can do like that. uh, but and that is structured. Like once you formulated the questionnaire, you did the preliminary testing and all, it is working, then you are not supposed uh, in between to change the questionnaire. It is fixed to whomever people you are asking, that is fixed. So that is a structured questionnaire. But in case of qualitative data method, it is always unstructured. You need to have a general idea what you are going to ask, but it can vary. During the due course, you feel that the question should change, you can change. So here, one of the thing, when I ask you to do a questionnaire, um, partly breaking something called of this structured and unstructured. Because in case of qualitative, we when if now you are going to make a qualitative questionnaire, but you should remember the pattern also, the type of questions. But you should also know that in qualitative questionnaire, actually there is nothing like that structured. uh, this questionnaire is just an indication that you are not deviating from the topic, or so many other things are coming up. Know that you're going in one way, but it is not like a um, quantitative study where you have to strictly follow. Like in a quantitative study, you felt somewhere during your study the your tool, that is your questionnaire, is not correct or something. That's why you were supposed to do a testing before. But even the testing you didn't find out, and you just went on, and you found out there is some problem, you are not supposed to stop it over there. If you had already collected the data, you have to move on with that thing itself. But here in case, that's why it is called a structure. It's already given a proper structure. You're not allowed to touch it. But when it comes to the qualitative data, be it in depth or focus group, there is no fixed questionnaire. The questions are there just to indicate that what are the questions you need to know, and that you don't deviate. But during the discussion, be that in-depth interview or focus group discussion, people may come up with different idea, something you have never thought of, and then you can change the question pattern. Like you just ask some other question which was not already in your prepared questionnaire. So that is what it's an unstructured questionnaire. So even when you're doing your research project, or later if you're doing PhD, in case you will know that even when now I asked you to prepare a questionnaire for the qualitative method, this is completely unstructured. This can change during the process, and that's the beauty of the qualitative, because you are dealing with the words. So the person is giving you something, then you can probe into that direction to get that. So the qualitative data collection, the questionnaire is always unstructured, where you just have a preliminary idea what you're going to ask. That's it. It is not that you're completely going to stick on with that. You're going to ask all these questions. No, sometimes you have the full freedom, not sometimes, you have the full freedom to change the questions during the pattern of questionnaire. So in case of qualitative, you don't have to keep a proper question pattern. If you see the PhD people, the thesis, in case of a quantitative, they will be having that structured questionnaire which they used for the study. But in qualitative, there won't be any such structured questionnaire because it will be varying. Some people you will ask that question, some people you will ask some other question. It varies according to the person whom you are interviewing. So for the example, the research question, the research question is how satisfied are students with their studies? So that is your research question. How satisfied are students with their studies? If it is a quantitative research approach, in case this is your research question, if it is quantitative, you survey 300 students at your university and ask them questions such as, on a scale from 1 to 5, how satisfied are you with your professors? Or you can perform a statistical analysis on the data and draw conclusions such as, on average, students rated their professors 4.4. So that is how you're dealing if it is in a quantitative approach. And if it is a qualitative approach, you are going to conduct in-depth interviews and see the number also. In case of quantitative, you are going for a large number of samples, 300 and all, or even more. But when it comes to the in-depth, because it is going to collect lots of words, even one person interview, you're not going to write it down. You're of course going to record it. So if the people, if you know someone who have done a qualitative study for their PhD, they will be having transcripts, pages and pages of transcripts. A lot, I should say, even if it is one person. So you don't go for a very large number of in-depth interviews. Even focus group discussions also, if you are doing, you do only 2 or 3 or 4 or 5, not more than that. There is a term that is used when the, I don't remember the exact term, but it means that when you feel that there is repetition of ideas, you're not getting anything new, that's the stage you understand that you need to stop it. You need not do any more in-depth interviews or focus group discussions because it's just the same repeat things you are getting. So there's a terminology for that. I'm sorry, I forgot that. That's the moment you understand that you can stop it. And usually it will be around 7 to 8 in-depth interviews and like that focus group discussion itself. So there is a number variation in quantitative and qualitative. So in qualitative research approach, the same research question, if you're going to do, you're taking 15 students and then you are asking them the question, how satisfied are you with your studies? So you're not giving them a scale to point it, to number it. You're just asking them, how satisfied are you? And you're not also giving the answer, yes, no, or a scale, nothing like. So they have to give you some words. Uh, am I satisfied or not? And if I'm not satisfied, why? And if I'm satisfied, then why? So you're going to get some words, some paragraph. You can ask what is the most positive aspect of your study program? What can be done to improve the study program? So you understand the question pattern for the same research question. Based on the answers, you can follow up questions to clarify things. That's why I told the follow up questions, it depends on the answer what they have given. So that is why the questionnaire, in case of focus group discussion or the in-depth interview, it should be unstructured one. You can add in a new question, you can delete a question. It depends upon the person who is answering. So you can ask the related follow-up questions and then clarify. Then after that, you have to transcribe that. And nowadays there are a lot of transcription software. Some of them are Dragon Naturally Speaking, Otter AI, Rev, Temi, Descript, HappyScribe, etc. And try to find out common patterns in it. Then there is combine both the methods, the mixed method approach. You do the quantitative analysis. You see that the same research question. You wanted to know how much the students are satisfied, and you got a number. Maybe we'll reduce it. 3. You got the number. Oh, we'll still reduce it. We get the number 2, and then you see that people students are satisfied only 2, and then you want to know why it is only 2, and then the question will go towards the qualitative approach. So in a PhD, you can do both studies together, the quantitative and qualitative. It will require a lot of time, a lot of resource, energy, etc. But you can do the mixed method approach. Or you can just confine yourself with the quantitative approach or the qualitative approach. It depends upon how much time and other resource you have to invest. So it's the same thing what I told, it is given over here. And then how we are going to analyze. We got the data. In case of quantitative data, of course, it is numbers, so we have to do the statistical analysis. We can do that analysis using the simple Excel, and Excel is not that simple, I know, but can do the analysis using Excel or the statistical softwares like SPSS, R, then another one there is SAS. So you can use this statistical software to do that analysis. And if it is qualitative data, there are softwares which help in analysis of the qualitative data also. One of it is, oh, there is a very common one. I forgot. Anyone remembering? Anyone? The software which is used for qualitative data analysis. Yeah, there is a very common one. One second. NVivo. Yeah. NVivo. That is a very common. This one, what is that? Software that is used for the analysis of qualitative study. So NVivo, I know only about that name. I have not studied in detail, so I don't know much about it. But what I have heard from the people who have done a qualitative study is NVivo will help in finding out some common patterns, some common words, and then they help us to transcribe it easily. Like you can get a common themes because you are dealing with the satisfaction. You get to know about people saying different words to indicate their dissatisfaction. They are not happy. They are not responsive to the lecturers' work they have been given. They're not happy. Um, mm, some kind of words will be repeated, and they can find that common theme. So qualitative content analysis is one of the method to analyze it. It will be tracking the occurrence, the position, the meaning of certain words, and then do an analysis. There can be a thematic analysis to find out the main themes and the patterns. Like from the words, understand like the person is saying, I'm sleepless, and from that, from just the word sleepless, we can't go into depression. But there are words like sleeplessness, not interested in doing anything, postponing the work to be done, and not interested in social activities. So these are some common themes, and then you can go like these themes are going towards depression. So like that, a thematic analysis can be done, and discourse analysis, studying how communication works in social context. But I don't know much in detail about this method. I know only about this much only about qualitative and thematic. As you all know, I have not done PhD, so I don't know much in detail. This is a general idea I can give you about that. So this is an activity that you can go, you can watch the examples of focus group discussion and in-depth interviews. Now for this questionnaire, the qualitative, always I told you like open-ended question. It is to reveal the opinion, the experience, some narratives or accounts of certain things that happened. Uh, it can be a precursor as it helps to identify initial themes and issues which can be explored further. Qualitative surveys frequently include quantitative questions also, like age, nationality, etc. So it is not completely qualitative. We need to add into the age, their gender, their nationality. Some questions like that will be there, but nothing that we are going to do a statistical analysis. We can just say this group of people, particular age group, they had the opinion like that. We can only go like that. Similarly, the structured interviews may follow a similar form of open questioning. The structured interviews means the other one, the quantitative one. The quantitative interviews also will be having open questions. So even when we say quantitative and qualitative questionnaires, both the questionnaires will be having some pattern. Like some structured questionnaires, the quantitative one, they will be having the multiple choice questions, and towards the last, there may be like, do you have any opinions to say about this? Every survey question, even if it is an online survey, even if it is Swiggy or Grab or whatever, they give it to how, initially the question will be from 1 to 10, how much you will um, give a point, blah, 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 blah. And the final question will be any suggestions to improve. So even the structured questionnaire, that is the quantitative methodology, even that questionnaire will be having some open-ended questions. And similarly, even the open-ended questions, that is the unstructured one for the qualitative methodology, they will be having some number questions, like to indicate age, nationality, etc. So it is not that exclusively one will be of particular type, there will be some commonalities, but it depends on how we are going to analyze it. In this case, as I already told, we can't make we can just come into a conclusion like this particular age group had this particular opinion in a qualitative study. But when it is taken for a structured interview, when this open question is asked, in the conclusion, we can put like many people or some of the people have a point and then say what you got in that open question. It won't be coming in that main analysis. So in case of FGD, this will be a usual pattern introduce. So this you can use as a direction to do your questionnaire. And whenever I say questionnaire, you should keep in mind in case of qualitative data collection, there is nothing like a structured questionnaire. You can change it at any moment. The questions can be introduced, can be deleted. It depends on which people or what people are saying. You formulate the next question. So keep that in your mind and then prepare one. So there will be a introduction, an icebreaker, because if it is a focus group discussion, people need to know each other in case they don't know. But it is always ideal to have a community in which people know each other. Then only they will be opening up. If you put a few strangers together, it is not easy to get ideas from them. Because there may be people who don't open, who are introverts, don't want to speak. And in FGD, we shouldn't have any people like that who doesn't speak or who doesn't contribute. So there should be, it's better to have a group of people who know each other. But the question should be like introduction and icebreaker, introduction to the topic, opening questions like broad open-ended questions to encourage patients to share their initial thoughts and experiences related to the topic. Then go to more exploratory questions to delve deeper into various aspects, their opinion, feeling, and perspectives. You can also go for the probing questions. Sometimes the person saying, like some question was asked, and all the people in the group was like, okay, I vouch it or I second the opinion. But then one person say, oh no, I'm not of that opinion, and then they stop over there. They're not giving anything clue, but you can ask further probing questions to get more idea, uh, to further probe into participants' response. It can be clarification, examples, or detailed insights. And you can add hypothetical questions, so what if questions, compare and contrast questions. Compare and contrast the experiences, viewpoints, or preferences. Then you can ask questions which will ask the people to rank or prioritize, to understand their preference and priorities. then what is their expectations or the future outlook regarding that particular matter, and feedback and closure. So your question pattern for your this one assignment should be somewhere around this pattern, but keep in mind it should be I mean it is unstructured. So the question pattern should be flexible and adapt to the flow of the discussion, that is unstructured. Encourage patients to interact with each other and ensuring that the conversation remains focused. And in case of in-depth interview, it is almost similar. You can go for the introduction, background information, open-ended questions, probing questions, almost similar. Opinion and attitude, behavioral patterns, motivations and influences, challenges, barriers. Because when it is about motivation, influences, challenges, barriers, only an expert can give you answer for these questions, not a group, unless they are more involved in it. Otherwise, it's not easy for some common group of people to give answers on challenges and barriers, etc. Then there also you can use feelings and emotions because that is the main crux of qualitative methodology. The comparisons, contrast, future outlook, and end it with feedback and reflection. So one thing is one is going more deeper, 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 and another one will be more wider, wider, wider. A general type, and another one is more specific type. So the closing conclude the interview. Thank the participants for this one. In focus group discussion versus in-depth interview question, one is group interaction and another is individual interaction. So that is one into one, one-on-one, one person, you and the other person. Insights in depth in FGD, it is about the group highlighting shared experiences and differing viewpoints. But in depth, it is going deeply into the thoughts and experiences and emotions. Facilitator's role, it is just to control or moderate the topic and to manage the group dynamics, that they are not going into their own discussions and that some people are not contributing, not like that. Everyone is involved. And in in-depth interviews, the interviewer guides the interviewee focusing on their responses. Data will vary also. We are going to get answers from different angles because many people are involved. But here in in-depth interview, it will be more individual narration. Richness of data. In one way, we are going to get the societal opinion, concerns, disagreements. And in in-depth, we are going to get the individual's unique perspective more deeply. Group influence, it is going to come up in FGD. In FGD, both things can happen. Like when a group is coming together, either people are going to say it openly or they may not even say. Both things can happen. Like uh, you want to ask about very usually sensitive questions are not allowed to ask the, but just to say this, you have a complaint, just go with the university example itself. You have a complaint about a particular person, a particular teacher or a lecturer. One of you is having some problem, and you are given the group FGD and asking about in general about the lecturer. So it can happen that that one person who have a problem with a particular lecturer, that question is asked, like, what is your opinion about that particular lecturer? The four people in that group, you all say in concerns, you are very happy about it. Then the other person may not be ready to say their opinion. Can happen other way around. So one person is hiding their emotions. Actually, we are not getting the correct data. It can happen other way around also. This one person had some issue with the lecturer. The person didn't want to discuss it with the colleagues. They never discussed. But such a focus group discussion is coming up. And other person may not be all four, but just one person open up saying that, okay, this issue is with that, I have with that person. So this second person who was until then keeping it as a secret, seeing that, okay, the other person is saying I can also be open, so they can open. So focus group discussion is like a peer pressure is completely acting. You get influenced by the people who are in the group. So as a moderator, you should be aware that such a bias is possible, and it is up to you to reduce as much bias as possible. You can't completely diminish it, but there can be some way to address it. So this group dynamics is going to influence individual response, either make them more responsive or they make them silent. In in-depth interviews, there is no external influences because it is just one-on-one. So they express thoughts freely. If this one single person is allowed to talk to one person, then the person may be opening up truly. Otherwise, they may not. Then time and context. It requires managing time for multiple participants' contribution in a session. But in depth, we can be more flexible with time and context. Like we can even have for a after job evening 5 minutes, that type of timing we can do. FGD, it's always 6 to 12, and I told 6 to 10, right? It's 6 to 12, but it's ideal to have lesser numbers. In-depth interviews will be individually. And moderator skill set, FGD, the moderator should be very able to control the group facilitation. And in-depth interviews, they require active listening and then probing. From the single word, the person, especially the politician, one single word the person says, from that they have to go into. So some qualitative study examples are this. I can go. So this is for the section 4 and 7. Have you taken a screenshot?
Yes, already.
Okay. So if there is any doubt now regarding its, I hope you're clear with the focus group discussion and um, in-depth interview, the questionnaire pattern, everything. And I guess you're not immature because if this section I'm going to do with my BHMS students in India, who are around 20s, the boys especially, I can even expect from my very dear backbenchers when I say it is an unstructured questionnaire, you can change the question in pattern. I can expect at least one of them will be coming up with a questionnaire which is very blank, saying it changes according to the group. I mean, it changes according to the answer the person is giving. So, because you all are matured, I'm very sure I'm not going to get such a response. Keep in your mind, it is unstructured, you can change, but you need to have a that you are on line itself, that you are not deviating from the topic. Only for that, you need to have a questionnaire in case of qualitative study. So that's all. We'll continue in the next class.
Okay.
If you any
Okay,
have
thank
doubt,
you.
yeah, any doubt, you can just ask me.